And this one is the gantry in Heidelberg that I mentioned before. You remember what was the concept of a gantry in a DINAC accelerator? Essentially, the whole accelerator rotates around the patient, but when you have a synchrotron for carbon ion therapy, this is impossible. So you have to build another magnet for bending carbon ions. But because of the high rigidity of the carbon ions at high energy, we are talking about the maximum energy around 400 MeV per nucleon. That's what you have to build. 670 tons, 22 meters length, 14 meters diameter, and the precision at the isocenter in the order of 1 millimeter for the reproducibility, let's say, of the movement. So it's a very challenging mechanical structure. I mean, now it's Japanese built lighter versions using superconducting magnets, but still we are talking about very massive objects. Okay, then in the second part of the lecture, I will focus on a few topics that are research topics for this carbon ion therapy, which is actually experimental, which is really an experimental technology. So you really need to do research, I mean, to get the full benefit from it. There are many topics from cancer stem cells, hypofractionation, FLASH, combined treatments, radiogenomics, biomarkers, intratumoral heterogeneity, hypoxia, non-cancer disease, and second cancers. I will touch on a few of them, not all of them, to give you a flavor of the problematics that we have in the research field. So for tumor background, genetic background, I mean, it would be nice to see whether it is possible to have a selection of the patients based on the genetics of the tumor. And this is interesting. You see, these are X-ray results on patients that are BAX positive or BAX negative and BCL2 negative or BCL2 positive. This is actually quite interesting because BCL2 and BAX are proteins involved in the apoptotic pathway, and so they suppress essentially apoptosis, and they are generally overexpressed in tumors. So for this kind of tumors, carbon ion therapy can be effective because, of course, you can induce cell death without apoptosis. Same for cancer stem cells. You know, the cells that are responsible for the reproduction of the tumor, the cancer stem cells. They are generally considered resistant to radiation, and they also generally go and live in hypoxic niche in the tumor. And this is interesting because, of course, we know that when you have resistant tumors or hypoxic tumors, then that's where radiation, heavy ion radiation is particularly effective. The other problem, we discussed last time of the application of immunotherapy together with photon therapy. Now the question is, what happens if we try to apply heavy ion therapy in combination with immunotherapy? Can this be better? The first thing to observe is that just like in X-ray therapy, also in heavy ion therapy, if you combine in clinics already, if you combine nivolumab, which is a anti-PD-1 checkpoint inhibitor, and you see in combination with radiotherapy, this is a 53-year-old male with pancreatic cancer recurrence after surgery. There is the treatment of para-aortic lymph node metastasis with carbon ions, but the lung metastasis also disappear. So that's interesting. You see the example of how effective can be the combination of immunotherapy and carbon ion therapy. One important effect to remember is that because of the sparing effect of radiation, you will have less irradiation of normal lymphocytes. And this is important because generally radiation-induced lymphopenia is a negative prognostic factor in many tumors. This is a recent paper in, for example, showing for esophagus cancer, the difference in disease mean-free survival for patients having severe lymphopenia in red and no lymphopenia or moderate lymphopenia in the dotted line. You see that these patients with severe lymphopenia are much worse, have much worse prognosis than those with moderate or no lymphopenia. And this is important because you see in this study, we have patients for uterus cancer, treated with uterus cancer with X-rays or carbon ions. And then we measured peripheral blood lymphocytes, chromosomal aberrations in these patients, the damage in these patients. And you see that even though the volume, the PTV is essentially the same, for X-rays, you have more damage than for carbon ions. This clearly corresponds to the dose distribution, so to the dose buff of IMRT in comparison to carbon ions. But you have more lymphocytes sparing. And in fact, this is for esophageal cancer. These are recent data from the MD Anderson Cancer Center in lymphocyte reduction in patients with protons in red and photons in blue. You see that those patients from proton therapy are better off than the patients with IMRT, but these results are almost the same as the results. This is carbon ions and this is X-rays. That shows, you see almost no reduction in lymphopenia when patients with esophageal cancer were treated with carbon ions compared to a trend to lymphopenia when you have a treatment with X-rays. So this is a paper of 2000, this is a paper of 2017, but the results are very, very similar. So this means, you see, this is a summary of data on the lymphocyte counts as a function of dose with IMRT, protons, 3D CRT, and carbon ions in esophageal cancer patients published in this paper. The other point I wanted to discuss is the possibility of treating non-cancer disease with particles in general. One promising one is certainly cardiac arrhythmia that represent a big problem. This can be atrial arrhythmias or ventricular arrhythmias. Ventricular arrhythmias are particularly dangerous. The current treatment for drug-resistant arrhythmias is the catheter ablation, which is very invasive and with the moderate rate of success. You see only 75% of success and severe complication in 6% of the patients. So the idea here would be to use instead radiation. Actually, originally this was proposed by Stanford. There is a company called CyberHeart that is actually using the CyberKnife. You remember the CyberKnife for treatment of cardiac arrhythmia. This is in a swine model here. And we proposed instead to use the BRAC-PIC, essentially to use carbon ions. And the problem is not easy because in principle, you see, to the three spatial coordinate and to the breathing of the patient, you have to add now the movement of the heart. So it's a 5D problem in general. And this is the example. You see, this is the treatment of the two atrioventricular nodes of the atrioventricular node and of the left pulmonary node. In a static treatment plan. And then, of course, with the motion, you see the change induced by motion in this treatment plan. We treated the swine model. You see, that's our experiments in the same cave that you have seen before with the patients. We use now that cave. We have no more patients at GSI, but we can treat pigs. And the PET, you see how useful it is. This is the treatment plan. where we were targeting here the ventricular tachycardia, so it's a ventricle. This is the in-beam PET, where you see the signal here. And this is the offline PET, where you see that the signal is gone because of the washout. So that's why it's nice to have a PET on the couch, because really gives you the opportunity to accumulate data online. So the 5D problem is complicated, but is feasible. So this can be actually treated, and that's what is now becoming more and more used. I mean, there is now SBRT in the clinics and for cardiac arrhythmia, and we hope to have more and more particle clinical trials. Secondary cancers, I told you before that this is a problem for radiotherapy, and it is a problem also when you have, in particular, when you have IMRT, we see, because you have an increase of the beam on time. We have seen the data for Hodgkin's lymphoma showing no improvement with the modern techniques, but can be also a problem for hadron therapy. This can be surprising because you say, well, but you're supposed to spare normal tissue. True, but you can have neutrons, neutron production. So in principle, what you would expect, you know, from for the risk of second cancer, comparing IMRT, 3D CRT, and protons, is that in the low dose region, you will have definitely a large improvement for protons, while IMRT will be worse than 3D CRT because you have a larger volume. And then instead, in the high dose region, 3D CRT will be the worst in terms of risk, and followed by IMRT, and protons will always be better. Now, if you go to the lymphoma case that we discussed last time, this is an old paper from 2000, and it's not a measurement, it's a simulation, showing that indeed, if you compare two opposite fields, 3D CRT for Hodgkin's lymphoma, this is the relative risk of second cancer, IMRT 9 fields practically the same, but pencil beam scanning protons, you should have a very substantial reduction in the risk that you see here. And this is another paper showing a more realistic treatment plan with carbon ions and protons, showing that depending on the kind of tumor, for some patients, carbon ions do better than protons. For other patients, protons do better than carbon ions, but both are better than photons. And this is for the distal part, so for the production of neutrons. It should be, this is an interesting experiment where in this phantom, the beam was shot in the head. You see now this is the phantom, and this is the tumor. So the beam was shot in the head, and then the distal dose was carefully measured from the head to the pelvic region, to the stomach, let's say. Different treatment were used. Protons in Uppsala, the green, are passive scattering. Protons at PSI in blue is beam pencil beam. Carbon at HIMAC is passive scattering. Carbon at GSI is pencil beam. And photons in Frankfurt, this is 25 megavolt photons. So they have a large, you see, it's the worst somehow in terms of stray radiation and photoneutrons. Then you see an impact in the production of neutrons by passive scattering, but pencil beam, you see, is very nice, is very effective in reducing the distal dose, because of course, in passive scattering, you have a lot of material in front of the patients that produce neutrons. But in pencil beam scanning, you can only produce neutrons in the patient. And in fact, from the epidemiological point of view, these are data from the United States with protons, showing that in general, you have a lower risk of second cancer in patients treated with protons compared to the patients treated with X-ray photons. There are still a lot of questions, of open questions of research here in this field. I'm not going in detail here, but I want to show you this one to show you how the neutrons can be important. This is a passive scattering neutrons, passive scattering protons at MD Anderson for a 9-year-old girl receiving craniospinal irradiation for a medulloblastoma. This is the dose. You see, very nice, of course, because if you do this with the X-rays, you have to irradiate the whole body. But here you have essentially all the dose in the brain and the spine that are the targets of the irradiation. Now, this is the risk of second cancer mortality, and this is the risk of second cancer incidence. And this is interesting to see. You see that the risk of incidence is still similar to dose distribution. The risk of mortality is definitely shifted, showing that now the risk moves to the abdominal part, where you have very low dose caused by neutrons, essentially. But this very low dose in these organs like pancreas or stomach that have relatively high mortality drastically increase the risk of lethal cancers here. So that's the kind of maps that we would like to produce, let's say, to provide the medical doctors with for their analysis of the best treatment to use. Finally, a few words about neutron therapy. Neutron therapy is, we have seen already a little bit of neutron radiobiology. You know it already. They are very effective. The effectiveness depends on the energy. And of course, you see, this is the energy dependence of the RBE, where the low energy have higher RBE than high energy, but also the OER, as you see, is definitely lower than 3. So you have, it's supposed to be very effective for radioresistant and hypoxic tumors. However, it's also very effective for late effects. It's a standard, you see, these are neutron experiment in carcinogenesis in this is acute myeloid leukemia in 2 different kinds of mice. And you see it is much more effective. Neutrons are much more effective than gamma rays. Moreover, they also reduce the latency time. So the tumors induced by neutrons also have a lower latency compared to those induced by photons. The quality factor of neutrons, we will come back to this in the radiation protection, but we have seen it already previously that is very high, it's about 20 at low doses. So for late effects, they are very, very interesting. And this gives you an idea. This is an important table that I got from an old book. It's not easy to get this data. On the dose average and track average LET, for neutrons, the fission spectrum neutrons that are around around 1 MeV peak, and then monoenergetic neutrons. The unit here, make no mistake, the unit is MeV. Let's see if I can, MeV per gram per square centimeter. So this means 750 really means 75. But you see, it's a fairly high LET. You are talking about a fairly high LET. This is dose average, and this is track average LET. You see that they are also substantially different. You see the dose average and track average. I think I touched this already in the physics lecture. The track average is the first moment of the LET distribution. And the dose average is the second moment of the LET distribution, which means that it's weighted for the dose, if you want. So it gives more weight in the average to the neutrons that give a dose. And you see that the difference between track average and dose average is substantial. But generally speaking, the LET is pretty high for fission spectrum neutrons. And when you go to high energy neutrons, the dose average LET is also pretty high. So they are effective, you see. And this is the range of LET. And you see, this is not 60s. In kV per micron would be 6. And percentage of those in each interval for fission, 3 MeV, 6 MeV, and 14.6 MeV MeV neutrons. So that's I think interesting to see. You see here, I mean, the MeV per square centimeter per gram is 10 keV per micron. Actually, neutrons were soon used for therapy. The first patient was treated by Dr. Lawrence, who was the brother of Ernest Orlando Lawrence in Berkeley. And they were, you have to use fast neutrons because you need penetration, of course. And they are generally produced in this way, you see, like using a beryllium target, and that's the energy, depending on the energy of deuterium, you can have a peak around, these are with 16 MeV deuterium, and this is with 50 MeV deuterium. And then the peak you see is around 6-7 MeV here and 20 MeV here. The other way that you can do instead is using protons on beryllium, and in this case you see that the neutron energy will have this kind of spectrum here. These are again cases there are no gantry for neutrons, so generally the patients are irradiated in a sitting position. And of course, the problem that you have is that in most cases you produce these neutrons from reactors. If instead you can use accelerators, like this is a proton linear accelerator for neutrons, then this can be a little bit more comfortable. However, the studies on fast neutron therapy were terminated essentially at the beginning of the 90s. Essentially, when this paper came out, this was an English study that was a phase 3 clinical trial comparing photons and neutrons for pelvic cancers. The study was stopped because, as you see here quite clearly, the toxicity was too high. The patient survival was clearly reduced using neutrons, and then the study had to be stopped. Why is that? If you think about it, I mean, neutrons is a high LET radiation like carbon, but unlike carbon, the depth dose distribution is like X-rays. So it's a particle that has high LET everywhere and has very severe side effects. So this is kind of expected from preclinical radiobiology that neutrons will not be a very good idea for treating patients this kind of tumors. I mean, it's a little bit different when you go to salivary gland tumors, because salivary glands are very superficial, so you don't have to go through many organs at risk. And so you can have a very good locoregional control using neutrons, but the salivary gland also, unfortunately, the patients do not have a very long survival anyway. So the toxicity of neutrons is not very severe problem in that case. These are examples of study results, you know, on salivary gland showing better local control and better survival. You see at 2 years, the survival with neutrons was 62%, while the survival with photons was 25%. So for this specific case, you have an advantage. Of course, these patients will have toxicities, but not so severe in the salivary gland. These are examples of salivary gland tumors. You see very large and disturbing tumors before treatment, and after treatment, you see that the patient is now essentially back to normal. There are now, as you see, the severe radiation-related morbidity, even for salivary gland, is still too high. You see, in most cases, except for these studies in 1994 in Germany, in most other cases, the toxicity is over 10%, in some cases greater than 15%, which is definitely very high. But still lower, let's say, than the toxicity that you have for internal organs, for deep organs. At the moment, fast neutron therapy for this high toxicity has been discontinued almost everywhere. In this paper in 2015, there were listed 4 centers still active, one in US, one in South Africa, one in Russia, and one in Munich, actually. At the moment, I think that the one in Munich is really the only one left doing fast neutron therapy. On the other hand, instead, with neutrons, but this time not using fast neutrons, but using thermal neutrons or epithermal neutrons, a technique which is increasing is the boron neutron capture therapy. Boron neutron capture therapy, the idea is to exploit the nuclear reaction that you can have shooting thermal neutrons on boron 10. If you shoot thermal neutrons on boron 10, this reaction has a very high cross-section, is 3,837 barns, extremely high. And the result of the interaction is that the boron decays in lithium and alpha particles, short range, very effective in cell killing, and in a gamma ray. So if you can load the tumor with boron and then you shoot neutrons, this technique can be very effective, of course. The problem that you can have is this one. You see, this is the depth in penetration, and this is the dose rate here. And the problem is that, let's say, the ADDR is the advantage depth dose rate. And you see that the problem that you have here is that if you go too deep, you lose this advantage. So the dose to the normal tissue becomes comparable to the dose in the tumor. So a thumb rule is to use quasi-thermal neutrons for depth less than 2 centimeters. If you want to go a depth higher than 2 centimeters, which means very, very shallow tumors, then you have to increase the energy of the tumors, of the neutrons, which means that you have to move from thermal to epithermal. You pay this in terms of reduced cross-section. The cross-section will be lower, but you gain it in terms of depth that you can reach with epithermal neutrons. So the failure of the first BNCT, at the beginning BNCT was not very successful. This was mostly due to the fact that thermal neutrons were not going deep enough, as you have seen in the plot before. Boron levels in blood were higher than those in tumor. You were not able to target the boron in the tumor. Excuse me. I think you don't see me anymore. The boron levels in blood are higher than those in the tumor. Viable tumor was found at depth following doses that exceeded the tolerance of normal surface tissues. And the trials in Brookhaven and MIT, Massachusetts Institute of Technologies, were stopped in 1961 for this reason, but we're talking about many years ago. BNCT was introduced in Japan already in the 50s, so it's an old technique in a way that has been, however, revived recently because of the use of epithermal neutrons that you can produce at small accelerator. The other problem is the thermal neutrons, you take them from the reactors, but epithermal neutrons at a sufficient flux, you can produce them at the accelerators, dedicated accelerators for BNCT. And also you have much better boron delivery agents now, like LBPA and BSH, that can be quite specific for the tumor. So you can have a very high concentration of boron in the tumor. And at the moment, you see the results of this trial in 2008 for glioblastoma. There is a lot of hope, let's say, in glioblastoma that, as I told you before, is one of the most difficult tumors because it's infiltrating. It's not metastasizing, but it's infiltrating in the normal tissue. So when you treat it with surgery or radiotherapy, it comes back. Chemotherapy doesn't work very well because it's difficult to go through the the blood-brain barrier. And there was a hope, though, that it was able to absorb a lot of boron phenylalanine, the BPA. But the results, you see, this is the survival of the patients with glioblastoma treated with BNCT. You see that at 24 months, at 30 months, there are no patients surviving, essentially. This is typical, unfortunately, of glioblastoma grade 4. The efficacy, you see that the conclusion of the authors was that the efficacy of BNCT in the protocol seems to be comparable with conventional radiotherapy. But the observed side effects and the requirement of complex infrastructure and higher resources emphasize the need of further phase 1 and 2 studies, especially directed to improve the accumulation of boron in tumor cells. So essentially, no success, also for glioblastoma with BNCT. So there are several BNCT centers and others growing too. This is, you see, is quite diffuse in Japan, but also in Europe, in Finland, in Czech Republic, and in Argentina, in Buenos Aires. But the number of centers is growing because of the accelerators. And interestingly, there are new clinical trials coming. This is, you see, November 7, 2019. There is a clinical trial for malignant melanoma and angiosarcoma using BNCT. And this was my last slide. Thank you very much.